So if you're unable to hear, hopefully you can hear me, but here's the instructions on the mute button. It should be down at the bottom for you to make your audio adjustments here, test your speaker. So hopefully everyone can hear me. I know there was one person who couldn't connect to the audio. Maybe you could dial in if you needed to, but let us know in the chat if you're still having that problem. And everyone has been muted and cameras cut off for this webinar. So if you have any questions, we're going to be taking them in the chat. We're going to try to allow time for them at the end and get to as many of them as possible. Also, this webinar offers closed caption. There's a link in the chat box here at the top. I will pop it back in momentarily if you need to use the closed captioning. And also, let me start recording. Awesome. All right. So just want to go over our NNLM Code of Conduct. These community agreements we have to cultivate equity, community, and wellness during this presentation. We ask that you support and use these agreements as you participate today. Please use welcoming and inclusive language, be respectful of different viewpoints and experiences, and show courtesy towards others in this webinar. So who is NNLM? Well, there's a lot of acronyms that go with us. We have NNLM, NLM, NIH, RML. So we have NIH, which is the parent org, and then NLM is an institute of that. And then we have my organization, which is the Network of the National Libraries of Medicine. We are the outreach arm for NLM. We have 7 regional offices and then 7 regional medical centers, offices, and other things such as NEC and etc. Other acronyms that you can become affiliated with. So you do have a region that serves you if you are in the United States or one of the territories. And here's a map here that'll just kind of show you where you're located. I'm located in Region 1, which we're at the University of Maryland, Baltimore, and these are the states that we support. So what do we do exactly? We offer free webinars, classes to librarians, health professionals, and the general public, anybody who's interested. You also have, we provide access to a network of libraries and other organizations. Some of you that are librarians may know, or if you're in a medical center through DocLine, it's one of our big things that we support. And then we also do funding for health information outreach, digital equity, and data services projects, even professional development. So that's kind of the big 3 of what we do here. So what can you expect today? So today's webinar, our objectives are to discuss national trends and data trends in maternal mortality, severe morbidity, and racial disparities in maternal outcomes, identify historical and current factors that contribute to racial disparities in maternal health outcomes, and review innovative maternal experience survey and understand how the data of the maternal experience can inform new models of care and contribute to health equity. So next we have our featured speaker, which is Dr. Lisa Giddens-Williams. She's a graduate of Cornell University and Temple University Medical School, completed her residency in OBGYN and fellowship training at the Maternal Fetal Medicine at Rutgers in Newark, New Jersey. She's director of OB at University Hospital in Newark and a professor in the Department of OBGYN and Women's Health at Rutgers Medical School. She's a practicing maternal fetal medicine specialist. She also serves as chair of the Maternal Health Awareness Day Committee, also known as ACOG, for District 3. She's legislative and vice chair for the New Jersey section of this. She's also director of OB at the University Hospital, an inner city hospital that services diverse patient populations. In this role, she serves as the department patient officer, leading quality improvement and safety efforts. Her focus has been on the implementation of nationally recognized perinatal safety initiatives and the development of new models for patient care. She developed and implemented the navigation program for high-risk pregnancies, the lifestyle centering pregnancy program for obese and diabetic women, and the equity birth plan to assure attention to social determinants of health. These novel interdisciplinary programs create new models for care delivery with the focus on pregnancy as an opportunity for long-term disease prevention, addressing racial disparities and outcomes. She also serves as trustee for the New Jersey Partnership for Maternal and Health Child, an advisor to the Greater Newark Health Care Coalition and the New Jersey Prematurity Prevention Initiative, and also a consultant to the state of New Jersey Maternity Report Card. So welcome, Dr. Williams. I'm going to take you off of mute. Let's see, did that work? It should have. Yes, I did.
Thank you so much for inviting me.
Yes, we're so happy to have you. So that's my question slide. That's at the end, everybody. You can just kind of disregard that. So I'm going to stop sharing and then allow you to start your screen. Thank you so much.
Can you see my screen?
Looks great.
Confirmed. Thank you.
Very good. Well, thank you for inviting me. I'm so excited about talking about this topic, but I'm also really interested and excited to talk with librarians. And when I discussed with my colleagues that I would be speaking to librarians, they expressed, how frequently we are running to the library and asking all of our trainees, those of us in academic medicine, asking our trainees and ourselves, looking up information and asking the librarian. So asking the librarian to help us sort through the mounds of data and information that's out there is amazing. You are a tremendous resource. So I'm excited to be a resource to you. So again, my topic is addressing racism and informing new models of maternal care to promote health equity. So my learning objectives are to discuss the national data trends in maternal mortality, severe maternal morbidity, and some disparities. Let's talk about some historical and current factors that contribute to racial disparities in maternal health outcomes, and then understand how data on the actual maternal experience can inform new models of care and also contribute to health equity. So for my disclosures, I have no relevant financial disclosures. In this presentation, I'll use the words mother, maternal, she or her, in reference to the birthing person. But I recognize that not all birthing people identify as mothers or women. And I believe that all birthing people deserve patient-centered care, which will help them build families and live healthy lives. That is my life's work. And so these terms are also used in this presentation as referenced in the source literature. So who are the lost mothers? And so this image that you see in the lower corner was printed in ProPublica in 2016. And they were talking about, printed actually in 2017, but they were talking about the number of pregnancy-related deaths that occurred in 2016. And at that time, they reported that there were 700 to 900 women in the United States who died from a pregnancy-related cause. And the writers found this astonishing because they felt that most of these deaths go unnoticed. And in fact, they started placing pictures to identify who are these women. They called them the lost mothers. And at that time, the importance of this was great because most literature did not report, and most public reporting did not identify these women. They were typically lost in an obituary. It just mentioned that they died, but there was not a lot of information about the fact that they died related to a pregnancy-related cause. So that was in 2016, 700 to 900 women died. But in 2021, 1,206 women died during pregnancy, making the United States have a maternal mortality rate that's higher than any developed country. And so I will tell you that behind every statistic is a story. So who's talking about maternal morbidity and mortality? It's all over the news now. Dr. Shalon Irving was a CDC epidemiologist who researched health disparities, and the news reported that her postpartum concerns were overlooked, leading to her death from complications of high blood pressure in 2017. After a routine cesarean section, concerns about the health of Kara Johnson, a successful entrepreneur, were ignored until it was too late to save her life. And her husband, Charles Johnson, has testified before Congress about this travesty. And only after demanding that she get the care she knew that she needed was Serena Williams, a United States tennis champion, able to receive appropriate care after she suffered from a postpartum pulmonary embolism, which is a blood clot that can be life-threatening. So everyone is talking about maternal morbidity and mortality. And here's the reason why. So in the United States, the maternal mortality ratio, the number of deaths per 100,000 live births, was greater than most industrialized countries. And if you look at the bottom line on this graph, the red, that is the maternal mortality rate in the United States. And you can see that it is higher than Australia and Japan and Spain and Italy and Germany and France and other developed nations. And one might say, well, the United States population is diverse and it's multicultural and it's multilingual, and those other populations have a fairly more homogeneous population, so they don't have quite as many problems as the United States does. But when you look at the mortality rate for non-Hispanic white women, which is in the pink above the red, that rate is still higher than all of the other developed nations. So the United States has a maternal mortality problem. There are three commonly used terms to measure maternal death in the United States, and while they all capture some aspects of maternal death, they're not equivalent. So I just wanted to go over this a little bit. So maternal mortality is the death of a woman while she's pregnant or within the first 42 days from the end of her pregnancy. And that's irrespective of the duration of the pregnancy or the site of the pregnancy. But the death is from any cause that's related or aggravated by pregnancy or its management. So this would not include death from accidental or incidental causes. And the reason why maternal mortality ratios are important is because they're used by the World Health Organization in international comparisons. So that's that death per 100,000 live births that we talked about. So an example of one of these types of deaths would be a pregnancy that's outside of the uterus or an ectopic pregnancy, and that causes a maternal death. Or a pregnancy-related condition such as hypertension or preeclampsia. But it wouldn't include, for example, the death of a pregnant person in a car accident. And maternal mortality in the United States increases significantly with age. And this gives me pause because I do take care of many women who are 40 and over. So if you look here, there are three different age groups depicted: under 25, 25 to 39, and 40 and over. And you can see that over the years, and also with increasing maternal age, the mortality rate increases significantly. And it's 138.5 per 100,000 for women over 40 in 2021. But in general, maternal mortality is rising in the United States. And this image that you see here depicts maternal mortality by race and Hispanic origin. And it gives data from 2018, which is the blue, to 2021, which is your light purple. And that second set of data is the rate for non-Hispanic Black women. And you can see here, without even looking at the numbers, by the graph itself, the mortality rates for non-Hispanic Black women are significantly higher than for all other groups. But Black mothers have been more likely to die than white mothers for over 100 years. And so these data have been produced by the Commonwealth Fund. And they compare the mortality rate of Black women to the mortality rate of white women, with one being equal. And you can see, based on this graph, that for the last 100 years, the mortality rate for Black women compared to white women has been significantly over one. Well, what about maternal deaths beyond 42 days? Because a tremendous number of women die after they leave the hospital, and death beyond 42 days. So this requires further exploration. And so a pregnancy-associated death is a death within that first year after pregnancy, regardless of the cause. So this makes up the whole universe of maternal mortality. And within there are pregnancy-related deaths. Those are deaths that were caused by a condition related to pregnancy, such as hypertension, complicating pregnancy. But there can be also pregnancy associated but not related deaths. That might be a death by an accident. That might be a death by homicide that's happening to a pregnant woman within that 1 year of life, 1 year after delivery. And these rates are very important. They're used by the Center of Disease Control and Prevention to evaluate maternal death in the postpartum period. So half of pregnancy-related deaths actually occur after the date of birth. And these data are also from the Commonwealth. And they reported that 52% of maternal deaths occur after up to 1 year in the 1 year postpartum. So oftentimes this is after the patient has left the hospital, when she's home, supposedly enjoying her newborn baby, perhaps getting back to work, taking maternity leave. This is when a significant number of deaths occur. And this has brought attention to in the medical community to what we call the fourth trimester, paying attention to the woman in the first few weeks after she's delivered. But I say we need to pay attention to this mother for that entire year. And you'll learn a little bit more about that why. So even higher education doesn't protect Black mothers from pregnancy-related deaths. And these data also from the Commonwealth Fund show that college-educated Black women have a maternal mortality rate that's higher than non-Hispanic white women without a high school degree. So it is not education, it is not economics, it is not insurance that are causing these disparities. And when we think about these disparities, we have to understand that it is something else that is causing Black women to have higher mortality rates. When we look at preterm birth rates, they're similar to maternal mortality rates. And this slide shows the preterm birth rates and grade. This data comes from the March of Dimes by state. And as a country, for premature birth, the United States got a D+. So I don't know about you all, but if any of my children came home and told me that they had a D+, we would be talking about we should be able to do better. And so the United States should indeed be able to do better. And if any of you are living in any of the states that are marked red, those are the states that got an F for prematurity. I happen to work and live in New Jersey, and New Jersey is proudly now boasting in the green a B+ for prematurity. And that has been a significant change for the state of New Jersey. But when you look at racial disparities, the prematurity rate is not the only indicator, because in fact, many of the states that had good scores for prematurity rate have significant racial disparities. And so in the dark purple, you will see the states that have the greatest disparities in prematurity rates by race. And overall, the US disparity ratio is 1.26, meaning that non-Hispanic Black women have a higher prematurity rate than non-Hispanic white women. And when you think about where are all of these premature births occurring, March of Dimes actually listed rates by city. So if you are in any of the cities that are living in or working in any of the cities that have an F, your prematurity rate is too high. And those include places like Philadelphia, El Paso, Texas, but I'll tell you, it also includes the city of Newark, and that is where I work. The interesting thing about this data regarding prematurity rates by city is that these cities are determined by where the mother lives. It's not by where she gave birth. So that doesn't mean that the hospitals in your city or where you live are substandard by any means, because the data comes from where the mother lives. But we know that women birth at many different hospitals, and they may actually give birth at a hospital outside of the city where they live. But nevertheless, it's telling that a large portion of cities have an F for prematurity rates. So what exactly is killing pregnant women? When we look at the causes of death, these are some of the top ones. Hemorrhage is number one. So that's bleeding. That can happen in the hospital during the delivery, or that can happen when the woman goes home. Hemorrhage is a leading cause of death. But one of the other top leading causes of death is cardiovascular and coronary conditions. So that's high blood pressure or diseases of the heart. that can cause maternal death, both during the pregnancy, but also significantly in the postpartum period. Infection, heart muscle disease or cardiomyopathy, embolism or a clot, like we talked about Serena Williams, preeclampsia and eclampsia, conditions of high blood pressure in pregnancy, and then also mental health conditions are a leading cause of maternal death. So the pregnancy mortality ratio for Black women with at least a college degree is 5.2 times higher than their white counterparts. Again, leading us to think we need to address racial disparities and we need to look at racism in the healthcare system. When we talk about mental health, more than 600,000 women each year suffer from maternal mental health disorder, depression, anxiety, PTSD. But less than 10 to 20% actually get any treatment. 1 in 8 women report symptoms of depression after giving birth. 1 in 5 say that they were not even asked about it in their prenatal visit. And half of the women with depression are not treated. So depression and anxiety are far more prevalent in Black mothers. This study looked at drugs, suicide, and homicide in the United States, and they found that deaths due to drug use, suicide, and homicide constituted 1/5 of the deaths that occurred during pregnancy and the first year postpartum. I mean, this is really significant because we do need to pay attention to drug use in the postpartum period. We need to pay attention to homicide, suicide, domestic violence, and the prevalence of weapons in the home, because these are things that are causing some of these postpartum deaths. The maternal mortality review committees from 36 states compiled their data, and maternal mortality review committees are statewide committees that look at the charts and data from each death and do an analysis. And when this committee looked at data from 36 states, they found that 53% of these deaths are occurring in the postpartum period. That's 7 to 365 days postpartum. 82% of the deceased lived in urban counties, and the causes of death were similar to the ones that I previously mentioned. Well, what about the maternal health workforce? What's so different about the United States than all of these other countries? And this slide is depicting the maternal health workforce, both by OBGYNs in the light blue and midwives in the darker blue. And you can see for the United States, which is the second from the bottom, that the midwifery workforce and the OBGYN workforce per 1,000 live births is significantly less than many of the other developed countries with far better maternal mortality statistics than the United States. So the United States is really suffering from a paucity of healthcare workers to support the births that we have in the United States. But maternal mortality is really only the tip of the iceberg, because we are collecting data on those mothers that die. But what about those mothers that it's a near miss? The mother suffers from something very significant during her hospital stay or during her pregnancy that can affect her future reproductive life, that can affect her health in general, and certainly can affect her mental health, because she really is having an experience that she did not anticipate. And so those other conditions are called severe maternal morbidity. They're indicators of near miss situations. You can think of it like that. And they are things that could portend maternal death. And so the Center for Disease Control and Prevention cites 21 of them, and they're serious things. You don't have to be a clinician to know that an acute myocardial infarction or renal failure, cardiac arrest, needing to be on a ventilator, sepsis, shock, these are significant problems that can happen to women. And so it's also important that these are also tracked. And so data suggests that severe maternal morbidity after discharge in women is a real problem. And the burden is significant, and it's not just for economically underserved women. In a Medicaid population, about 1 in 6 women suffer from a severe maternal morbidity event, and in a commercially insured population, it was 1 in 7. When we looked at the timing of severe maternal morbidity, 3/4 of these events were occurring within the first 2 weeks of discharge. So that really means that there has to be an attention to mothers in those first few weeks when they go home. And there are certainly racial disparities in severe maternal morbidity. The odds of severe maternal morbidity among Black women are 1.7 times higher than that of white women. So the way forward is for us to expand and look at these rates of severe maternal morbidity, but also to drill down on what is causing all of these disparities. And so we talked about how celebrities have been in the news with their pregnancy complications and sadly with their maternal death. But more and more often, local news is also promoting and reporting these events. And I have colleagues all over the country. And so whenever a maternal morbidity or maternal mortality is reported in the news, they will send this to me. And so I don't live in Milwaukee and don't frequently read the Milwaukee Journal Sentinel, but this was sent to me by one of my friends in 2020. And this is a story of a woman, Tashana Ward, a 25-year-old daycare teacher who in the postpartum period went to the hospital trying to get help. She had chest pain. She was waiting and waiting to be seen. And after waiting for several hours, she left, went to her car, communicated with her family, and was later found dead. She died soon after from a postpartum complication. So the importance of postpartum follow-up really cannot be stressed. And so part of our mechanisms of improving maternal health is to pay attention to this postpartum period. This is a graphic that the Center for Disease Control and Prevention put out showing mothers that death can happen up to a year after the delivery and that women should be highly attentive to that. And because the racial disparities are so strong, the Center for Disease Control and Prevention came up with this campaign called Hear Her. And it's promoted by the sports celebrity Allison Felix. And it encourages women to speak out. And it actually created a script card. Like says, if you go to the hospital, say this. And in my practice, we literally teach patients, if you go to the hospital, do not sit and wait in the waiting room or do not leave without being seen, but speak up. And so the Hear Her campaign empowers women to speak up, but it also empowers and encourages the healthcare providers and the healthcare system to listen to women. And it also teaches family members and communities to recognize maternal warning signs. Now, the outcome of this endeavor and campaign is really unknown. The data will prove itself. So how do we get from having our reality that there are disparities in health outcomes and disparities in resources and treatment? How do we get to the stage of health equity where we're doing what we can for populations that are receiving disparate care? And for that, we really do have to address racism in the obstetrical environment. And one of my colleagues gave me this slide, and she said, if you're tired of hearing about racism, imagine how the people who experience it are feeling. And I think that's really true because it is exhausting for the patients and it's exhausting for the healthcare community. So what about biases and how do we really know that they exist, right? Everyone thinks that there are biases, but is the healthcare system really so biased? This study looked at racial biases in pain assessment. And it challenged the hypothesis that there's a difference in pain perception. Is there a difference in understanding of pain perception by white medical students? So they surveyed half of white medical students and residents and found that they believed myths about racial differences in patients. They actually thought that Black patients had less sensitive nerve endings and thicker skin than their white counterparts. And they found out that those who endorsed these beliefs were less likely to treat their Black patients with pain. So you can imagine your patient or a patient goes to the hospital thinking that she's going to get treated for pain, but in fact, the pain gets ignored or under-recognized because of these false belief systems. And this is one of the first studies that really actually measured these differences in belief systems amongst learners and amongst healthcare providers. And then fast forward to the OBGYN literature itself. These investigators looked at racial disparities in postpartum pain management to see whether or not, test the hypothesis that there were differences in the way Black women's pain was perceived. And in fact, they demonstrated that Black women, although they may have reported higher pain scores, they were less likely to receive narcotic treatment for pain. And similar disparities in treatment in the pediatric literature, in the emergency room literature, have been demonstrated. So what else is affecting the way that Black women get differential care? One of the ways that they are getting differential care is through the use of algorithms. And so vaginal birth after cesarean section can be an option for women to reduce the likelihood that they need a second or third cesarean section. And so in carefully selected patients, this is an important delivery option that can reduce the risk of morbidity and mortality. And because it's very clearly reported in the medical literature that a vaginal birth is less likely to be associated with complications than is a cesarean section. And so VBAC, or vaginal birth after cesarean section, as the acronym goes, can be an option for women to reduce their morbidity. However, there have been calculators that take into account race in determining whether or not a woman is a candidate or whether or not she will be likely to have a successful vaginal birth after cesarean section. And so the use of these calculators and algorithms preferentially discriminated against Black women because they put race into the algorithm, stating that if you're Black, you're less likely to be successful. And many women were coached using these algorithms and using this calculator. And so that calculator has subsequently been withdrawn. These authors called out and said why equitable access to vaginal birth requires the abolition of race-based medicine. And they were absolutely correct. The VBAC calculator has been revised to remove race because there's nothing inherently different about a Black body that would reduce her likelihood of having a successful vaginal birth. And also relative to the use of algorithms in medicine in general, these authors in this article entitled Hidden in Plain Sight ask that we reconsider the use of race correction in clinical algorithms because race as a social construct is difficult to use in these algorithms. And what it does is it suggests that the patient has a poor health outcome because of her race. So what about in the OBGYN world? There are more disparities and more algorithms that have hurt Black women. And so the American College of Obstetrics and Gynecology once reported that there would be different levels of anemia that required treatment for Black women. And so they subsequently withdrawn this and have determined that there's not a reason to have a different anemia cutoff for Black women. This is really important because anemia and hemorrhage can be causes of maternal morbidity, and hemorrhage is one of the leading causes of maternal death. So if you can correct anemia, you might prevent a woman from suffering an untoward outcome in the delivery episode. So rethinking race in medicine caused ACOG to remove race-based cutoffs for anemia. And in fact, the obstetrics and gynecology had made a racism statement. And that statement says that, race is a social category. It's not biologic or genetic condition that elevates risk for certain conditions and health disparities. And that racism has been and continues to be systemically embodied in our society and in the practice of medicine. Racial health inequities are the result of upstream and downstream impacts of systemic racism on lives and health and well-being of Black, Indigenous, Hispanic, Latino, Asian, Native Hawaiian, Pacific Islander, and other historically marginalized populations. And further important are that the intersection of other identities such as gender, sexuality, ability, religion, and others can further influence and multiply the impact of racism on individuals and communities. And I think that really says it, that we really do have to look at the impact of racism and how the medical community has fostered it, but how the medical community can lead to the change. And so the March of Dimes, in collaboration with the American Hospital Association, shares this dismantling bias in maternal and infant care. There's actually an implicit bias test that one can take to self-evaluate implicit bias. And organizations are encouraged to go to this website and review the history of structural racism in the United States and think about racism in maternity care, how you can mitigate it, and how you can build a culture of equity within an organization. And in addition, the American Hospital Association has promoted this film. It's called Toxic. It's a Black woman's story. It was first developed by the Cleveland Pregnancy and Infant Loss Committee, and it really explores toxic stress, microaggressions, racial inequalities that negatively affect Black moms and their birth outcomes. And this film really talks about stress, and we know that stress is a biologic construct and that stress can cause biological changes, including hypertension and other untoward health outcomes. And it has been biologically measured as allosteric load. And so this is a tool that hospitals can use to really start the conversation about racism, start the conversation among healthcare staff, social service professionals, educators, women in their family about issues that are really critical to improving health equity. And so this is a tool that is available on the American Hospital Association website. So when we look at maternal mortality and severe maternal morbidity data, there's a lot that the data doesn't address, right? We get these rates, but what's the story? Who's the person behind those statistics? The data doesn't address access. And so having insurance doesn't mean that you have access, because it doesn't mean that you have transportation, that you have money for your prescriptions and other devices that are part of the therapeutic and treatment plan. Do you have the ability to take days off of work? Do you have childcare constraints? Do you have fragmentation of care, meaning that you go to the hospital that's close to you on one day, and on another day you go to the hospital or the healthcare facility that's close to your work? So healthcare can get fragmented, which can lead to untoward outcome. It doesn't address how concerns and complaints are discovered and addressed. It definitely doesn't address systemic racism. And the data doesn't address differential treatment of women of color. And when we think about that, we have to think about what access do patients really have. And so this map of the United States, the red in the map shows you where there are maternity care deserts. So if you're living, any of you living in the more in the central part of the state where there's a lot of red, those are places where there's not full access to maternity care. Orange is low access to maternity care, and only in the purple is full access to maternity care. So based on what I already told you about the number of providers and the paucity thereof, you can see why there are maternity deserts. So how do we get to listening to the voice of the mother? So the Listening to Mothers 3 survey was published. It was a survey that women answered about their birth experience. And there were 2,400 mothers who answered this survey about their birth experience. And they were asked questions such as, did your race, ethnicity, cultural background, or language interfere with your care? And so, whereas 86% said never, a significant amount said yes. You had over 11% that said yes, usually, always, or sometimes. And the rates of yes, sometimes, and always were higher for non-Hispanic Black women. And then a further survey from this Listening to Mothers is the Listening to Mothers in California. And these data compile the results of women who were giving birth in California during 2016. And so out of the women that were asked these questions, whether or not they felt that they got unfair treatment based on their race and ethnicity, about 11% of Black women said yes, which was sometimes, usually, or always, compared to 1% of non-Hispanic white women who said sometimes. So clearly there's unfair treatment, and it's reported by the patients. In further asking about the maternal experience about birth from the Listening to Mothers survey, mothers were asked whether or not anyone used harsh or threatening language towards you. And so Black women, as well as Asian Pacific Islanders in this study, more often reported that they were the victims of harsh or rude or threatening language, and that they were also handled roughly. Again, the data, mortality and morbidity data, don't talk about experience. So the World Health Organization has some dimensions of mistreatment, and they believe that respectful care is a global priority. Global health experts agree that how people are treated during childbirth can affect the well-being of the mother, child, family, and can have long-lasting outcomes. So, and poor treatment really can impact outcome. In 2017, they published 8 standards of quality for maternal and newborn care, and 4 of the standards demonstrate that respect, dignity, and emotional support are really important. But little is known about how much mistreatment contributes to the outcome. So this is a really interesting study, giving voices to mother. They actually looked at inequity and mistreatment of mothers during pregnancy and during childbirth by distributing a survey. And there were over 2,000 women that completed all sections of the survey, but 1 in 6 women, 17%, reported experiencing mistreatment, such as loss of autonomy, being shouted at, scolded, threatened, ignored, refused, or receiving no response to requests for help. Factors that were associated with a lower likelihood of mistreatment included having a vaginal birth, having a midwife, being white, and being older than 30 years old. And 27.2% of women of color with low socioeconomic status reported mistreatment, compared with 18.7% of white women with similarly low socioeconomic status. And very interesting was, regardless of maternal race, having a partner who was also Black increased the reported mistreatment. That's pretty telling. So also the 5 most common forms of mistreatment that reported were being shouted or scolded at, being ignored, violating your physical privacy, threatening to withhold treatment, or being forced into a treatment that you didn't want, or generally being threatened in any way. So this is a really important study that reflects that the voices of the mothers really can lend information to us about what's happening in the healthcare system. The American Journal of Obstetrics and Gynecology reported this article in March of 2023, and it's from Every Mother Counts, which is an organization that promotes advocacy, storytelling, and listening to women. And they are representing women in both the United States and also internationally. And so they recommend that the patient's story and the patient's lived experience is very important. And it's that there should be mechanisms for reporting disrespectful care. They stated that Black and Indigenous and other women of color face a consistently higher rate of dying from pregnancy and childbirth than white women. And that's a fundamental injustice that's rooted in structural and interpersonal racism. And how they recommend that this information gets out there is so multifold and multi-pronged, through research, through advocacy, through education, and also through filmmaking. And so they promoted a film series and developed a film series, Giving Birth in America, which describes the birth experience of women in different parts of the country. Another film was No Women, No Cry, which also reports birth experience and really sheds light on some of the disparities, racial disparities in the birth experience. And so using stories and getting information out there in another way is a very powerful tool. Likewise, the Preeclampsia Foundation, another not-for-profit organization, talks about the importance of the voice and views of the patient and the family. And this organization was founded by patients that had untoward experiences with high blood pressure and preeclampsia during their delivery episode. And so a review of the organization's history is listed in this article and depicted. And then they also have some quotes from women. One New Jersey woman said, as an unmarried Black woman, I felt vulnerable, and now I was scared. Looking back, another quote, the warning signs were there, but they were disregarded. So patient stories are qualitative data, And they add to the information that we have that is quantitative, that gives us our maternal mortality and maternal morbidity statistics. It's important to understand that trauma after a postpartum hemorrhage or a stillbirth or any other unplanned birth event can be scarring to the woman for the rest of her life and also to the family. So how do we get to these maternal experiences? The New Jersey Maternal Mortality Review Committee reported that among the 44 pregnancy-related deaths in New Jersey from 2016 to 2018, 36.4 were Black, 8.6 were Hispanic, and 18.2 were white. But when they looked at the pregnancy-related mortality rate for Black women, it was 6.6 higher than for non-Hispanic white women. So that's Black women dying at a rate 6.6 times higher than for non-Hispanic Black women in New Jersey. So New Jersey recognizes that there's a lot of work to be done. And so these are some opportunities for improvement. And here you'll also see the maternal mortality rate for Black women in New Jersey. It's the red line at the top, and you can see that it's significantly higher than other groups. Blue being white, purple being Hispanic, and Black is the total. And the statewide infant mortality rate, while also decreasing, there's significant disparities. And we talked before about the disparity ratio for Black-white infant deaths. And so this is New Jersey's data, going down for Black women on the top in the red, but still markedly different than for other groups. So the Maternal Experience Survey is a product of the NAACP, the National Association for the Advancement of Colored People. And they came up with this model, the Maternal Experience Survey, to get the experience and to chronicle the experience of Black women in New Jersey and to contribute to the opportunities for change. So it was developed by the NAACP and the Atlantic City Black Infant Maternal Mortality Task Force and the Prematurity Prevention Initiative. And the Prematurity Prevention Initiative is under the direction of the Family Health Initiatives. The entire project was supported by a grant from Community Health and Wellness and the New Jersey Department of Health. So in this picture, we really want to thank this woman whose image here, her name is Takima, for sharing her story and also the beautiful image of her family. This was done in collaboration with Nice Media Group. It's a Black-owned storytelling business. And the actual full story of Takima can be seen at njpreterm.org. And she says, after sharing her story, it's still a journey I feel like I may never recover from. So the Maternal Experience Survey is a community tool. It was designed and developed to reduce childbirth-related disparities for Black and Brown people. It allowed them to share their story in a space that was safe and embedded with identity, acceptance, and respect. The NAACP vision included sharing stories by Black birthing people of emotional and personal nature. It would be a tool to empower them within a system that does not respond to them well, and that it would find key data points that would allow us to delve deeper to solve some of these problems. So the Family Health Initiative is dedicated to helping nonprofit and public agencies throughout New Jersey and across the country take their missions to the next level. They use best practices, data management and analysis, and develop strategies and interventions tailored to meet the needs of specific clients. The Prematurity Prevention Initiative is a collaborative. It's a cross-sectional effort aimed at focusing on community engagement through evidence-based interventions, really with the goal of reducing preterm births in New Jersey. And so they use clinical expertise, clinical intervention, assessment, community engagement, but very specifically, the community voice. And then the NAACP Black Infant Mortality Task Force had its purpose to develop a community level action in response to the social and birthing injustice in New Jersey. And you saw those rates, so you can understand why this was a call to action. They wanted to develop a birth experience survey that was driven by Black women as the center of the storytelling. They wanted to be a resource source that was easily accessible to women, their partners, birth workers, community organizations, political leaders, government institutions, and whoever would be interested in Black infant and Black maternal mortality knowledge and statistics. So the recommendations and the recommended participants included the NAACP, hospital and healthcare systems were invited to participate, maternal health organizations, they engaged elected officials, residents and community members, and that is the committees that set out to launch this project. So what is the structure of the Maternal Experience Survey? It was divided into 3 sections: prenatal, labor and delivery, and postpartum. So women could answer about their experiences in any of the sections or in all of the sections. It used inclusive format, and health literacy and language were taken into consideration. It was user device friendly, so it was a survey that participants could complete on their phone, on their tablet, on their computer. It was available in both Spanish and in English. And the survey was incentivized, and with the thought that women, they wanted women to really understand that their time was valuable and that they wanted them to be heard. So there was a small incentive to the participants after they completed the survey. And the survey also linked women to additional resources that could help them at any point in time during their pregnancy. The survey, of course, required consent, and interestingly enough, most women consented for their stories to be told. 100% of the respondents indicated that they agreed to share their story. And one woman wrote, "We should be part of the birthing process, regardless of our age or race or sexual orientation or anything other than our child's needs in that moment." So it was very clear that women who answered the survey cared about having their stories told. So the survey was distributed throughout New Jersey. The counties where there was the most response and where there was a lot of community action were in the southern part of the state and in the northern part of the state, and that's where we got most of the responses from. But this is a map of New Jersey, and these are the number of participants that completed the survey in New Jersey as of the most recent reporting date, which was March 28th. Again, where a community advisory board was in place in Atlantic, Camden, and Essex County, we did get the most responses. And those are also the counties where there are the most disparities in maternal and infant health outcomes. By year of pregnancy, women they could report their data or their experience based on any year of pregnancy that they wanted. And interestingly enough, although this survey was put out more recently, women reported about birth experiences as far back as 2015. And oftentimes they were reporting that birth experience that was so far back because it was traumatic and they hadn't gotten over it, and they remembered very well that experience. But most of the experiences were later on, and we do have some from the pandemic. We have 2020, the beginning of the pandemic year, 2021, and the collection of these surveys is still ongoing. By year of pregnancy, we have these data. These are the responses by the year of pregnancy. So some of them were currently pregnant, some of them recently gave birth, and then we have it broken down in between Spanish and English. 59% completed the full survey, all parts of pregnancy, in English and in Spanish. And then others participated that recently delivered. They completed it when they recently delivered, 26% in English or in Spanish. By race and ethnicity, although the survey was directed towards Black or African American women, all voices were heard and all voices were able to be heard. So 51% of the those that completed the survey were Black or African American, not Hispanic, but women of all races completed the survey. And by age groups, most participants were in the age range of 25 to 29, but younger women carrying pregnancies or postpartum between the ages of 15 and 19 also completed the survey. So there's clearly an interest in women giving that information. And regarding racial identity was self-defined by women in these surveys. They had the opportunity to define themselves as Black, non-Hispanic, white, Hispanic. Race and ethnicity were two separate questions in the survey, and they could select, and they could also self-identify by free texting in their response. So here's some results of the Maternal Experience Survey. These are statewide data. So one woman said, my third pregnancy was difficult because I had many discomforts, but my doctor is great. She has known how to control each one of my discomforts and everything is going well so far. But another one said, I'm an immigrant. I just relocated to the United States. It wasn't an easy time, especially regarding racial profiling and of course, transportation to attend the prenatal visit. I could barely afford. I was thankful that it ended with a live birth. And when we asked the question, did you receive prenatal care? You can see in the circle that 12% of women did not receive prenatal care. And that's tremendous because we know that prenatal care is the one thing that can significantly improve pregnancy outcome. One other woman said, I didn't feel free to express my concerns and I couldn't get information from the nurse practitioners that gave me care to continue with them for postpartum. Another said, I was in constant pain due to my diagnosis. Being high risk was a struggle. The doctors were concerned for the baby and not at all concerned that I was in pain. Another said, I started bleeding and I had a threatened miscarriage. My doctor made me feel more comfortable, assuring me that everything would be just fine if I took it easy. And although it was scary and I had just miscarriage, I followed the instructions and took it easy and gave birth to a beautiful baby boy. So through the Maternal Experience Survey, Black and brown birthing people are honored and they're asked to give their specific experiences to us. When the Maternal Experience Survey asked women about negative treatment, we received the following data. Based on race and ethnicity, 71% of Black women said that they did not at all experience negative treatment by their prenatal provider. But look at the number that said somewhat, a little, and a lot, and that's 3, 11, and 15% of Black women said that they had a negative experience with their prenatal care provider. This is in marked contrast to the circle on the right, where you can see that these are the responses of other races, non-race or ethnicity, excluding Black women, and most said that not at all. 89% said not at all. Some comments were, in my first pregnancy, I had preeclampsia. My OB didn't explain the risks. I quickly learned once I was at the hospital that my education should have started during my prenatal visit, explaining what can happen to me and my baby. I had to have a C-section. My pain was not addressed. Maybe I believe no one believed my pain. Another said I had private insurance and my own OBGYN. But after attending nursing school, I knew why my concerns were ignored. Implicit bias. Another said, my provider has a very diverse staff. For prenatal and OB, there are Black and Latina doctors. It was much more competent culturally, and I felt supported. My doctor advocated for me, and I was treated respectfully. My doctor was also able to provide me risks and statistics on how these things impacted me. based on my race and ethnicity. And when we ask the patients about their support person during the delivery, again, this is really important because we know that doula care, and a doula is a birth attendant that can support the patient throughout the labor and delivery process. We wanted to determine whether or not women were laboring alone or whether they had a doula or family member present. 89% said that they did have a support person, but 11% said that they didn't have anyone when they were laboring. One woman reported the following. She said, "Unfortunately, I had an unexpected home birth, but my doula provided support over the phone. She met me when I arrived at the hospital, only to find out that I was positive for COVID, and although asymptomatic, and both my partner and my baby were negative. Postpartum, my doula assisted me with breastfeeding over the phone. She sent me instructional videos. Since I was returning to school in the summer, she helped me develop a pumping schedule. So having that support, even over the phone, made me passionate about everyone having that experience during their childbirth and postpartum, regardless of their socioeconomic circumstances. The only thing I would have changed about my birth was having taken childbirth classes sooner. It would have helped me identify the signs of labor that I failed to recognize, resulting in a home birth 4 weeks early."
Dr. Giddens Williams, I hate to interrupt you, but we do have some participants that needed to leave. So I wonder, would there be a way people could see this to be able to read some of these? Do they have to live in New Jersey?
No, well, they can have these on my slides.
Okay, awesome. Thank you so much.
Okay, I'm going to continue. So regarding whether or not they're bringing up questions or concerns after the delivery, again, 61% said that they had no discomfort bringing up concerns, but 40% said that they did have discomfort bringing up concerns. And so whether or not they experienced complications when they went home, 61% said they had challenges at home, and a smaller percentage said that they did not have challenges at home. And these are some of their comments, which can be available to read. I'm going to skip that. So what the Maternal Experience program did was it developed a program of ambassadors to increase the rate of a number of surveys that were completed. They sent out ambassadors into the community asking women to complete these surveys. And the ambassadors were trained, they were compensated, and they went out in the community spreading the word about this maternal morbidity and mortality, but also encouraging women to complete the surveys and get their voices heard. So the ambassador program ran for 3 months between March and June. The ambassadors logged in about 2.5 hours of time each week. They established efficacy with the communities. They gained skills that allowed them to transfer knowledge, and they increased awareness of the Maternal Experience Survey. And so they were trained, they got a tablet, they connected to patients via social media. They went out into the community. Again, they took information to the patients that could inform them of maternity-related risks, and then they got them to encourage them to complete the Maternal Experience Survey. So these are some of the kinds of things that they explained to the patient. They talked about preeclampsia, about high blood pressure. This was also during COVID time, so they explained COVID precautions. And as you can see here on the flyer that says Maternal Experience Survey, there was a QR code that the moms could scan, and that took them to the survey. And then the ambassadors helped them complete the survey. Ambassadors would have a direct outreach to the patients. They did that via social media, via email, and also via text message. These are some of the ways that the ambassadors met with the patient. They posted it on their social media. They dropped off flyers in the supermarket. They went to churches. And so the point is that they were meeting women where they were so that they could understand their experiences. And this is outside of the hospital setting, because we know that in the hospital setting, many women were not feeling comfortable actually speaking up about their experiences to the healthcare team. So the next step would be really to try to replicate this program, to share the maternal ambassador program, and also amplify the Maternal Experience Survey as a way of getting more information about the patient's experience in the healthcare setting, and also look for additional opportunities and community involvement. And so for the acknowledgements for the Maternal Experience Survey, it is the NAACP, the Perinatal Cooperative, the Family Health Initiatives, the Prematurity Prevention Initiative, and thanks to the New Jersey Department of Health and the Black Infant Maternal Mortality Task Force Advisory Board and the Maternal Experience Survey team for promoting this project. So where does this leave us in terms of models of care? It's pretty clear that we need more providers and we need more specific programs. Patient navigators can be tremendous help. There's someone that would help the patient with appointments and assuring that they have transportation and that they know where to go for specialty care. There are types of programs such as lifestyle pregnancy programs that would be specifically designed for mothers with specific conditions like hypertension, diabetes, obesity. Centering pregnancy is a group prenatal care that empowers women, but also allows them to share their story and has improved pregnancy outcome. We need a culturally congruent workforce. We should engage communities and doulas, and we should train preventive medicine and internal medicine residents to help us with that postpartum period. We have to make awareness to our colleagues about the postpartum risks and morbidity and mortality. Programs that enhance remote blood pressure monitoring and case management can also help. Postpartum navigators, having people follow up with patients in that postpartum period, 42 days to 365 days postpartum is also really important. Collaboration across health systems, having birth plans that recognize the social determinants of health, these things like experience surveys, and then partnering with community-based organizations that elevate the voice of women. And so that very important ones would be the Black Mamas Matters Alliance and the National Birth Equity Collaborative. So in the White House blueprint for addressing maternal health, this came out in 2022, the White House item by item went through what the federal government can do to improve this maternal health crisis. But what was very important is that they said bolster the voices of the communities of color to better understand pregnancy-related death. And I say it's not just to understand pregnancy-related death, but to understand the maternal experience that leads to severe maternal morbidity, near misses, and then chronic stress in the aftermath of a birth. When you think about what the federal government is doing, this slide lists some of the initiatives that have been passed regarding maternal health. And I'm pleased to say that New Jersey's a yes on all of these. Some of them include a midwifery policy where certified nurse midwives are reimbursed, doula legislation so that women can have a doula that's supported and reimbursed. 40 states have maternal mortality review committees. 48 states have perinatal quality collaboratives that bring together experts to support best practices. So those are some of the successes to this maternal crisis. But this also requires a literature reassessment. And we talked a little bit about algorithms, but really overall organizations are making a call for addressing structural racism as a fundamental driver of health disparities. And the American Heart Association published this in Circulation 2020. It said we need to move beyond statements that report on well-known disparities in burdens of risk factors, disease, and outcome among specific groups of the population to intentionally addressing racism and structural inequalities. So in literature, how is race defined? How is ethnicity defined? And are they attributing something to race that ought not to be attributed to race? And an article in 2022 in the American Journal of Obstetrics and Gynecology created a correction because Dr. Claire wrote an editorial saying that the race was not the factor, but racism was the factor. And these authors were promoting that Black race was a risk factor for preeclampsia. And the editorial writer said, no, it's not race, it's racism. And we should address what is driving these underlying disparities. And so as we think about that, we need to think about what are these structural and social determinants of health: safety, food stability, access to care, income, education, what are the rates of incarceration in the community. And so these authors actually recommended not just looking at structural determinants of health, and social determinants of health, but structural determinants of health and root causes of inequities. So the facts are clear. Black women are really more likely to die in childbirth, but 80% of the deaths are preventable. A Black woman with a college degree is more likely to experience a pregnancy-related death than her white counterpart. And childbirth is just more dangerous for community of color because they're disproportionately impacted by morbidity and mortality. But when we start looking at data and the causes and current and historical factors, the voice of the patient will be likely to lead the change. So challenges to the librarians: you all are the keepers of data. So be aware that there are going to be new investigators and new people looking for this data. So it's going to be beyond medical personnel. It'll be public policy people. It'll be legislators and, in fact, filmmakers. And we talked about the films produced by Every Mother Counts and supported by Every Mother Counts. But they are documentary filmmakers looking at maternal health and putting this information out there. Direct the researchers to new data, including data that's generated by community of colors and minorities and those who are historically unidentified or under-identified. And that means that there's literature out there that may not be cited regularly. There may be literature out there that's not in high impact journal, but are by minority authors. And those have not been in the literature for other reasons related to systemic racism. Look for new data that has a different approach to race as causality, and look for experiences and narratives that will be more important in the maternal and child health space. And those are going to be integrated with maternal outcome data. And now there's a call for journals to have diversity statements and diverse editorial boards. So as you are directing others to literature, pay attention to that and to those diversity statements. And so my call to action is just spread the word about the maternal health crisis and racial disparities. Recognize that the information and misinformation might exist in the public literature. New data is going to evolve with different approaches to race. The Maternal Experience Survey in New Jersey was a novel program to educate women, but also elevate their voices. The surveys will lead and can be part of the toolkit. Find new ways to share the information. Remember that 85% of maternal deaths are preventable, and maternal deaths are a human right. And also honor the lost mothers, those who we know and who we have identified, and also those who are not so publicly identified. And that's all I have. Any questions?
I'm looking in the chat. First of all, thank you so much, Dr. Giddens Williams, for, I know your schedule is jam-packed, especially considering all that you're involved in and your actual care for your patients. So thank you so much for making yourself available to come here today and talk to us, and actually being excited about talking to librarians. So we're just as excited to hear from you. I don't have any questions in the chat so far. I know we've had some people that dropped off, but we may have to have you back only just for a Q&A. Considering how much you've given us today. So if people want to access the survey, oh, we do have one coming in. Can they do that? I know I tried once, but it asked me to state my New Jersey county, and I didn't want to skew the statistics, so I left.
No, so the actual survey is done by the participants, so you wouldn't see the questions.
Okay.
But those are going to shortly be posted on the website. So the first initiative of the survey was to put out the implementation plan and then describe it. And then the next part, once they had enough data from the varying counties so that the data would be not identified, they will put out more of the stories and they'll be posted. You will be finding them posted on the website. But certainly the stories that are here in my presentation can be shared with others. The
Great.
concept of the survey is really what we wanted to get out there, that there is an opportunity outside of the healthcare environment for communities to come together and get the stories of women. And what's really important about the survey is that it can be available to counties, to hospitals. Each hospital can actually get their own data once there are enough respondents. And so we have information about what's happening across the state. We also can get information about what's happening at an individual institution and what birthing mothers of a variety of races and ethnic backgrounds are experiencing.
Awesome. We did have one question come in the chat. If you can answer this one, it is, what do you think is the best way to get more midwives in the healthcare force?
Midwifery school. Midwifery school. You know, I learned my obstetrics from midwives. And so I think that they're a tremendous part of the healthcare team. But for whatever reason, the midwifery workforce in the United States, you saw the data, it's really small. And we need more midwives, and we need really like a, you know, culturally congruent workforce for it to solve this problem. You know, we're such a diverse country. Each state has its own, you know, its own diversity as patient population, and we need all kinds of healthcare providers. We need nurse practitioners. We need nurse practitioners. We need midwives. We need more OBGYNs. You can see the difference. So I would say anyone that's interested, look up, go to a librarian and get good information about midwifery schools.
Great. And I think we can answer this last one. We just have, thank you very much for this. Someone, a Black woman over the age of 40 and being terrified of the statistics, but that this information is very powerful. And then there was one last question that is, if you could briefly talk about an example of a birth plan that would recognize social determinants of health.
Oh, I would love to briefly talk about that.
Okay.
Well, here's the thing. So, you know, most birth plans, if you Google birth plans, librarians, you'll know this, you'll get millions of hits. And it tells you to think about, you know, bringing your pillow, bringing your aromatherapy. And I'm not discounting that those are really important things. Whether you want the cord clamped, whether you want to bond with your baby right away, whether you want to bathe the baby, there are a myriad of choices. But most of those birth plans don't think about some of the social determinants of health. So when I do a birth plan that's attending to the social determinants of health, I think, what might you need to do if you have to deliver prematurely? Because maybe you have an increased risk of preterm birth. And so I start talking about your birth plan needs to be making a plan. Who's going to be with you at the delivery? What if you go in early? What if you've had a prior preterm birth? What if you have another preterm birth? Who's going to watch your children? So it's involving making that kind of plan. If you're anemic, then your birth plan is to raise your hemoglobin, make sure you get iron. Maybe you need to come in the hospital and get an iron infusion, but we're working to make sure that you're not at risk for hemorrhage and you're not at risk for an untoward outcome. So that birth plan with regard to equity is thinking about, do you have are you able to get to the hospital? Do you live close, or do you need transportation? Do we have to figure out how you can get transportation? Do you need some accommodations at your work? You know, if you're not able to get to your appointment because you feel very stressed about what your boss is thinking about your pregnancy, how can we help you navigate that space? So it is attending to social determinants of health at a very different level. And I think that it goes through asking the mother, what's important to you about your delivery, and then what's going to help you have the safest delivery outcome.
That was a wonderful answer, and thank you so much for, putting that in perspective, because I do think that a lot of people, we just don't think about those things. We just kind of assume that they're givens, and there are definitely people that have to actually think about that as a part of their birth plan. So again, that's all the time we have. I know we ran over. Thank you everyone that could stay. Thank you again so much, Dr. Giddens Williams. And I see you put your email address at the bottom so we could email you if we needed to.
Yes.
And ask you more questions. And hopefully we can have you back. This was so wonderful. And I'm sure there's so much more that you could say. And we'd love to have you again to do another variation of this, or just more information, because there was a lot of information in this that was just so useful, and we really greatly appreciate it.
Thank you so much for having me. Have a great afternoon, everyone.
Have a great afternoon, all. Thank you so much. And we'll be sending this out.